Good evening. My name is Frank Milnar. Welcome to tonight's webinar. I want to really thank you for being part of this audience tonight. I live in St. Paul, Minnesota. I've been a dentist. Next year will be my 40th year into dentistry, and here you are in your universities and your junior, senior years waiting to get a diploma. And I'm so excited for you because you don't know the greatest gift that you're going to receive in your future is that you are in the world's greatest profession. And I want to welcome you and to tonight's webinar. And a little bit about myself is I graduated in 1976 from University of Minnesota. I'm an accredited member of the American Academy of Cosmetic Dentistry. There's 360 of us worldwide. I'm a board examiner. I'm on many editorial review boards for the articles that you read. I write, probably about 5 articles a year in the peer-reviewed journals, and I'm very passionate about dentistry, and it's because I've had good mentors, and I believe in the process of education. And that's going to be your path to walk and how you want to wind up in 40 years. That'll be you get to determine it. But dentistry is so fascinating. There's so many different pieces, from the patients that you serve to the people around you who work with you. It's going to be so rewarding for you. I do lecture a lot around the United States and internationally. I've lectured in the U.S. Armed Forces, and maybe some of you will be heading that way. And I salute you for doing that. These are great men and women who serve. Some of you might be going into general practice residencies, where I came from, the VA in Minneapolis. And anything you can do to further your education, join state organizations, the American Dental Association, Academy of General Dentistry. Do something to improve yourself and establish relationships with people that are more educated than yourself, and then you can have mentors to help you evolve your path. Tonight's webinar is sponsored by NEXTDDS and Shofu, one of my corporate sponsors that I work with. And Shofu is a wonderful dental company offering so many courses in continuing education, so many good products, as so many other dental corporations that sponsor education as well. And we want you to acknowledge these companies by buying their products when it's relevant in your budget, and that you've educated yourself before you purchase. A little bit of housekeeping tonight. The webinar will last about 45 minutes, and then I want you to, at the bottom, you can write questions and feed them into me and see how many we can answer for you tonight. And at the end, there'll be a survey, and you get to grade me. And one of the things that happens when you receive a diploma is nobody's going to grade you anymore. And your clinical instructors, after your boards, won't grade you. But you are graded. You're graded by yourself, you're graded by your staff, you're graded by your patients. It's a non-ending process that will never go away, and it'll determine your standards of excellence as you progress through your career in dentistry today. So let's get started with a webinar called Minimally Invasive Dentistry. I didn't start out being minimally invasive. Now that you're graduating from dental school, now your real education starts. And I'm not being facetious, it's the truth. When you begin your practice after you graduate, you're going to start building teeth. You can't wait to start building teeth. You are excited when you see decay. You are excited when you see disease. And then you start taking teeth apart and you start rebuilding them again. And then you're going to start building a dental team around you. Maybe you're going to go into practices that already have this, or corporate practices that are already provided for you. If you're not an owner, they don't see you as an owner. If you are working as an associate from somebody who owns the practice, you're going to be graded how you build the team and how you work with your staff, how you treat them. And I'll give you a little tip: you treat them like gold, and because they're there to help you, and you acknowledge these people around you who serve you as well as the patient. You're the last one who gets thanked. And ultimately, you're going to build a practice. One way or the other, you're going to build a practice. In the end, as time goes by, like me, what I recognize, I built trust. Trust and confidence in the people around you, trust and confidence in the patients that are dedicated to you. You build a reputation in your community. I built a reputation in my profession, with my peers, with my colleagues, and that's something that will never go away. And ultimately, you build a legacy. And what will be your legacy besides spending 30 to 40 years in a dental practice is how you serve your profession, how you volunteer, how you do third world dentistry, how you do things that don't benefit you financially, but how you serve the world that you live in. Our learning objectives are fivefold tonight. How to build in a good environment. This is not, hasn't been with me for all my career, but it's here to stay, and I'll share the tips. How to implement minimally invasive dentistry into your future dental practice. And I'll give you tips as we go along. Is your patients are savvy now. They know that you're new. They know that you don't have a lot of experience, and you don't want to experience failure prematurely with these people. Otherwise, you may not see them again. So we want to implement some minimally invasive protocols for you, and then what causes sensitivity issues and how you can prevent them. Another tip, sensitivity is with you all the time. It's like your shadow. It follows you wherever you go. And if you can manage this and get into predictable situations, you can negate how much sensitivity you'll experience in your practice. The fourth bullet point is how to minimally invasive preparations are the wave of the future. And your patients, whether you're on corporate dentistry, PPOs, DMOs, they've been online, they know what minimally invasive is. And the fifth bullet point is how do you communicate with your patients is really going to be probably a number one on the list. Is how do you talk to the patients and how do you get them to buy into you and what you say. Now, for disclosure, I work for many different companies, and I have no vested interest in any of the products that I show you tonight. Is that I am paid to do this webinar, and I'm paid by NEXTDDS and association with Shofu Dental, one of my sponsors. So let's start off. I always start off with philosophy, and let's talk about Einstein. He said the only thing that interferes with my learning is my education. Unfortunately for you, you've paid a lot of money to become educated as a dentist, and the half of the life of your education is very short. And you're going to have to be on a learning track all your dental career, because if you're not going forward and upward, you are going backwards very quickly, and the status quo is going to be something that you don't want to become familiar with. Nothing new happens when you don't try new things with sound principles and good basis for learning. Now, I threw this in here because I want to challenge you. Is that what is the difference between a 70-year-old dentist and you waiting to get your diploma and all these good pictures you're going to take for posterity and into the archives? You go. Well, the difference is experience. Experience is a tough teacher. First you get the test, then you get the lesson. And you will get experience, and I hope your experience is going to be a good one. And I hope you have mentors around you at all times, like flying an airplane. You don't take an internet course in how to fly. You need instructors all the way. Wisdom. Wisdom comes with age. Unfortunately, I can't tell you you're wise in your late 20s or early 30s. I believe in my 60s now, I'm becoming more wise all the time, and I can see the future by looking at the past. Know your limits. Don't overshoot the runway. I know you want to tackle anterior complex bonding. I know you want to get into indirect procedures. I know you want to restore implants. I know you want to do grafting. I know you want to do molar root canals. But please, listen to me. Do not do things that you are not technically trained to do. It may come back and bite you, and you may get the lesson of experience versus the reward of experience. Understand the risk. Every time you put your hands in somebody's mouth, there's risk. Every time you take a tooth apart, there's risk. Every time you build something, there's risk. You have to understand the risk yourself and explain it to the patient at all times where you are on the risk scale. And know the cause of failure. Mao Zedong from China once said, failure is the foundation for success if you can discern the cause of failure. If you cannot discern the cause of failure, you are destined to repeat it, and nothing good comes of that. So listen to me as somebody with wise principles. Know the cause of failure and be technically competent before you do it. Let's go back to this great profession of dentistry that you just are waiting to get into. Where did this all come? Where did this start? 5000 BC, there were dentists in the Egyptians, and toothaches were caused by worms in the teeth. And that's what the dentists thought then. There were copper wires in mummies' teeth, so they were doing root canal therapy back in the Egyptian days. The first dentists were 3000 BC, and 700 BC were the Etruscans, the predecessors of the Roman Empire, that were actually wiring teeth together on deceased bodies to keep them straight in the afterlife. They were having gold partial dentures, things like this. And if you look at the next slide, this came from that era. These were the first tooth implants, if you can believe it, with gold wires. And below is the first recorded toothbrush. This was called the tooth stick. Back in the Egyptian days, that's what they crushed mint leaves up with and brushed their teeth. So if you look going forward in time, 1728, Pierre Fauchard, there was the first recorded medical dental journal and with a section devoted to orthodontics. So that was significant. And then 1840 was the first dental school in Baltimore, and then 1795, I'm going to take you right down history here, George Washington got his third set of dentures. And we all heard that they were wooden dentures, wooden teeth, and not so. Most of the dentures at that time were made of horse and donkey teeth. They had lead bases for the partial dentures, and as you can see, they actually had spring hinges. So when you put those in, that you open and close with that. But I mean, that was in 1795. Obviously, we've come a long ways. Now I want you to look at this picture right here, because this picture was in the dental school in New York. This was in 1864. This was the first rubber dam. And maybe did your dental school look like that? I don't think so, but that's what their dental school looked like in 1864. Now let's keep going forward, and the first handpiece came in from Germany, as well as the first shade guides in the early 1900s from the denture factories. But the first handpiece, the E-motor handpiece, was 1887. And then if you look at the 1905, this is a breakthrough because Wilhelm Röntgen discovered the X-ray, and that's when we could start looking inside the teeth. That was revolutionary, and that obviously promoted dentistry and for what we could do with root canals and diagnosis. Now, let's take you in the early 1900s. How would you like to do dentistry like this? Well, this was stand-up dentistry using live mercury, hands in the mouth, and we're going to talk about this, but that wasn't too long ago. So wherever you are with your CAD cams and your apps and things like that, you got to remember that there's individuals that served 50 years doing this kind of dentistry. If you look now, the first silicate cements were in the 1950s, and about 1985 is where dentistry really took off on the technology platform and on an incline, a slope that has never changed, from digital x-rays to Invisalign in 1996, and then we came into CEREC, and then glass ionomers were by Wilson and Kent in 1972. And 1976, I want to let you know, it was a historical day in my life, is because I graduated from dental school. And I have changed. The way I look, the way I dressed, but I was ready to enter into dentistry, only trained with the education I received in 4 years of dentistry at the University of Minnesota, and then off to the VA I went. So let's go back to G.V. Black. I want to tell you, G.V. Black was a man ahead of his time. Not only did he give us the G.V. Black classification, cavity preparation classification, but he said that the professional man has no other right than to be a continuous student. How true that was. Maybe his classification of preparation has been replaced, but also he did say something that you didn't see in your dental school, perhaps, and he said the day is surely coming in the lifetime of young men, well, young men and young women before me, when we will be engaged in preventative rather than reparative dentistry. He said we will understand the etiology and pathology of dental caries and be able to combat its destructive effects. Welcome to Minimally Invasive Dentistry. Thank you, G.V. Black, 1926. So, let's introduce you to minimally invasive dentistry. Everything you do in life, whether you touch teeth or whether you walk down the street, whether you drive a car, has consequences. Short-term and long-term consequences, especially in dentistry. You get to decide which one it is, and it determines the survival of the tooth that you're going to work on and the dentition. You have the obligation to keep your patients dentate to the end of their human life, that they go to the final portions of their human life with their teeth in their mouth, albeit implants. You have to understand the consequences, short-term and long-term, of what you do. I'm going to take you back in the Wayback Machine. I'm going to take you back to G.V. Black, and I was tested on it because in my clinical procedures, if I didn't remove enough tooth structure, I got a bad grade. So I came out of dental school understanding the more I took away, the higher grade I'd get, and that kind of stuck with me. So let's talk about minimally invasive or not. Is this minimally invasive dentistry right here? MOD, buccal lingual amalgams, 4 pins, in there with Peter K. Thomas anatomy. Is that minimally invasive? Well, in effect it is, because we save buccal lingual cusps. Not too strong, but we save the cusps. Is this minimally invasive? When you have whale dent pins anchored in 4 corners with a root canal that somebody had to negotiate through the pins in the mesh to get into that, that's not minimally invasive dentistry. That is destructive dentistry. How about a root canal with a retrofill on the distal root? Is that minimally invasive? No, it's not. That's a result of cumulative trauma to the tooth caused by serial procedures done that escalated the destruction of the tooth and the nerve tissue, ending up that in that tooth survival rate is somewhat guarded. How about this? Somebody's invested a lot of money into bridges, root canals, posts, and now it is non-restorable. Is this minimally invasive? Of course not. You're going to see this stuff, and you kind of wonder what's going on and why does it happen. What about this? 2 Emax crowns surrounded by a little spicule of a tooth, a residual tooth. And is that good treatment planning? Of course not, but let's talk about that gold foil on tooth number 22 that's been in there 50 years. So that's minimally invasive because it's still there and there's a lot of options you can do. But remember, that gold work you see there, that's the sacred hunting ground of dentistry. You be very careful and you honor that dentistry and your patients, and you show them dentistry that's lasted 50 years. And you tell the people, you tell the patients that you've had very good dentistry throughout the years. Let's go over the fundamentals of minimally invasive dentistry. I was not taught this in dental school by any means. This is my own education. I've gone all internationally to study with the best minimally invasive dentists and learn from them and chart a new path. into which will last me the end of my career. What is minimally invasive dentistry today? It's emerging technologies, emerging underscored, to facilitate the primary prevention and the prevention of disease and destruction, prevent disease and destruction. And it's the science of detecting, diagnosing, intercepting, and treating dental disease on the microscopic level. Yes, you are going to be involved in this. And this is going to be on remineralization therapy, restabilization of the oral environment, pH strategies. You will be involved in this at some point. And the focus on this is the maximum conservation of tooth structure, especially enamel. Enamel is your best friend. You don't want to lose the enamel, especially in the class 5 cervical area. That provides a rigid scaffolding to protect the tooth from flexing and your materials, so you don't want to remove cervical enamel if you can't help it. And then the elimination of macromechanical retention, that means no GV black stuff. We're coming out of that era. You're going to replace some of it, but when you go into that tooth for the first time for these cavities in disease, you want to use micromechanical retention and adhesive retention in your preparations, and take advantage of the tooth's ability to remineralize and alter the oral environment to favor the remineralization profile versus the demineralization based on pH strategies. Now, let's talk about risk. You're going to have to talk to your patients about this, and I want you to write this down. This is really important. When you see patient smells, you look in there, and if you see no decay in the last year, or no decay in general, these are low-risk people. And if you see 1 or 2 new cavities in the last year, these are moderately risk patients. You have to tell them there's risk here, that somehow this environment, whether it's sucrose or pH of the saliva, that you are moderately at risk. And if you have 2 or more cavities, you're in the high risk category, and that before you build in this environment, you better understand the risk. You're at risk too, because if you replace dental work in a high risk environment, your dental work is not going to last long too, and patients are going to ask, are you a good dentist? And if you have rampant decay, you have extreme risk. So understand the risk by the American Dental Association and talk to your patients. This is the medical model, and whether you're going to get used to this or the insurance companies and or your government is going to mandate medical models before you treat patients, is that they want you to identify the risk assessment on these patients before you treat diseases. And then they want you to prevent and control through remineralization, and I'm not saying fluoride therapy here, but by preventing and controlling after you identify, and then only restore after the disease is controlled. So I'm afraid it's coming to you, and it may come to me before I retire, but it's going to come to you. It will be mandated, I believe, by the insurance companies before they allow you to work on patients with insurance and get insurance benefits from their companies. One of the words you want to talk about to your patients is the traumatic restorative technique. Is you list all these bullet points below, but you want to have the least traumatic procedure done to these teeth with the smallest burr, removing the smallest amount of diseased tissue, and maximize the adhesive qualities of the tooth in the enamel, and seal the dentin and minimize the sensitivity. So this is the atraumatic restorative technique. My staff knows all these words, and they talk all about these things before I get in the operatory. What we call now in cosmetic dentistry is responsible aesthetics. I don't care what your teeth look like on the websites, what your photographs looks like. I want to know how much tooth structure you conserved. I want to know what your preparation guidelines were, what your adhesive protocols were, and I want you to understand redo-odontics is a thing of the past. Is by just taking apart somebody else's work and putting new stuff in there, sealing it and putting white fillings in there. There's no future in redo-odontics. You're going to kill teeth. and they're going to wind up with root canals and things, and probably loss of tooth structure and the tooth. Is avoid the repeat restorative cycle, prevent that disease from happening again. With minimally invasive dentistry today, the risk is to the restorative materials and not to the tooth. These are reparative procedures. These are reparative materials. If they chip or break, you put them back and put them right back and don't take any more tooth structure out. You save that tooth for technologies that don't even exist today and new materials that haven't even been introduced. You put the tooth in the tooth bank and then you tell the people they have restorative options in the future. So what I want you to gain from this slide is, we used to say, we look from the outside in, oh, that's a nice looking resin filling, that's a nice looking veneer, that's a nice looking crown, that's a nice looking bridge. But that's top-down aesthetics. We want you to see bottom-up dentistry for top-down aesthetics. That means everything starts at the adhesion level. That's the most important level that you're going to put on any tooth that you touch, whether it's porcelain and or composite. It's the adhesive level. That's the epicenter of all dentistry. It must be sealed. It must be maintained to prevent micro leakage and things like this. This is the gold standard of today, is repairability. It is your gold standard of adhesive dentistry. It's bottom-up dentistry for top-down aesthetics. Sensitivity is caused not from enamel. Sensitivity is caused from the opening of dentinal tubes. Once you burn through the enamel with your burrs or your chase and decay, and you get through the enamel, and now you're into dentin, the game changes. The stakes go high because you're into a hydrophilic substrate of the tooth. It's the strongest structure in the body. And what you have are exposed dentinal tubes in a square millimeter of tooth structure. There's 10 to 30,000 dentinal tubes, and you open those up, and you better know how to seal those and what happens, because if you don't manage these dentinal tubes, then you have Brandstrom's theories. You have hydrostatic pressure coming up the tubes, and here comes the sensitivity. So this is what you don't want. So when you look at a slide, and a SIM slide of partially occluded tubes, the goal of any adhesive dentistry is to occlude the dentinal tubes, establish a hybrid layer with resin tags, and then you can build on your hybrid layer, and then you can build up on your porcelain and your direct restoratives. But if you don't maintain the occlusion of these tubes, whether you're using self-etchers or total etchers, you're going to experience sensitivity, and that includes your C factors and a lot of other things that elevate the risk. This slide right now is what nature did, the great architect, and show you that on these dentinal tubes, you have smear plugs in the smear layer on top. And this is good. It still has sensory qualities, but everything is sealed and nothing can go down the tubes, and the hydrostatic pressure doesn't come up the tubes. It's what happens when you start removing this stuff, and that's when the risk goes high. In a perfect world, you have the dentin, and you have the dentinal tubes, you have the hybrid layer of your adhesion applied properly according to manufacturer's specifications. You have your adhesion resins that go on top, and then you have your composites. And if you can manage your polymerization, shrinkage, strain, and stresses, then you can start building in your C factors. So what we see now is, I do not want you to overlook glass ionomers. Whether you had experience in dental school, is you have to have glass ionomer technology in your operatories, whether they're for your pedodontics, resin modified glass ionomers, for your resin modified liners that you're going to put in, whether you're for pure glass ionomer buildups. You have to know your ionic exchange adhesion and how hypermineralization works in reparative. This is your true reparative materials today. These are your smart materials, and become very familiar with glass ionomers. And if you don't have access to them, Go to some course and some manufacturer and learn how to do this. Let's talk about ethics, aesthetics, and economics today. What I want you to do is maximize your communication cycle with your patients, learn how to talk to them. I'm going to give you some tips in a minute. Engage the patient on the invasive ladder. Please start talking about risk before you start talking about how you're going to take their teeth apart and put restorations in there. Offer the least invasive treatment first. Underscore, I always say to a patient, you can do nothing. I don't care if it's silly. I don't care if they have rampant decay. I say, you can also do nothing if you want. That protects you, that protects the patient, it puts a buffer zone in there. And even though it may be futile on their part, always offer you can do nothing. And that's good by me. Offer the least invasive treatment first. Now you can climb the invasive ladder to say we can do something very conservative first, and if that doesn't work out, or if it works out to our benefit, then we can climb that ladder together and do some definitive restorative dentistry. And even though it might be more risky to the tooth, at least they can accept that risk. Discuss the prevention cycle, and that's not oral hygiene instructions, and it's not hygiene appointments. It's how you're going to diagnose the oral environment as a chemist and as a physician of the mouth versus a surgeon taking things apart. And biomimetrics, and that's how you re-engineer the tooth according to the rules and principles of nature. If it acts and looks like dentin, you put dentin substitution in, and if it acts and looks like enamel and stiff in the modulus of elasticity, then you put enamel equivalents in. You have to know the difference between dentin and enamel, and it's not Vita A2 materials. Everything is going to be different. Reproduce nature according to its characteristics. That means if it's going to be biomechanical in the dentin, that means it could be bioaesthetics in the enamel position, and that's how you create responsible aesthetics, and that means you're going to protect the dentin from sensitivity issues. Not everybody can afford expensive crown and bridge now, so you have to offer something less expensive, and these could be transitional restorations, glass ionomers, buildups like we used to do with amalgam. You're going to offer glass ionomer buildups or composite buildups until they can afford crowns and EMAX and PFMs and things like this. But most importantly, you're going to have a continuous adhesion, sealed adhesion from the apices, from your dowel cores to your incisal edge. Everything must be in the standards of excellence into adhesion principles. Mass produce your minimally invasive dentistry, and that's your future. You're going to replace Meyer dentistry from the GB Black era, but you're going to be producing minimally invasive restorations. And offer as a test drive, as a blueprint for somebody who can't have full mouth reconstructions, as you can offer some composite transitional restorations and test your theories of occlusion and vitality of the nerves if you're close to the exposures, and offer something before you get into full mouth rehabilitation. Quality tissue management, stay the heck out of the sulcus. That's what I can tell you. We were taught to go down to the sulcus and retraction cord, and with EMAX and lithium disilicate and these new aesthetic materials, you can go equigingival, slightly subgingival. Stay out of that sulcus. Nothing good happens when you put that margin deep in the sulcus. You don't have to do that. And provide predictable operative dentistry today. The fastest growing population today are the 80-year-olds and older, and they're going to have more wear on the tread on those tires, especially in the class 5s. You got to think, and if you get a young adult in your patient, sitting in that dental chair today, you got to ask yourself, if you're the first one on that tooth, how can that patient maintain the life of that tooth for the next 50, 60 years beyond you being their dentist? Before you remove enamel on a juvenile, think, what are you doing? How much enamel do you have to remove? I want you to become tooth and patient centered versus your education centered, because somebody calls you a doctor, that doesn't give you a license to remove tooth structure. It gives you a license to protect the tooth from damage for the life of the human cycle. That's what your goal is. I want you to look at what I worked in my environment today. And back in the 70s, this was what all I had, and this is what we did. We finally killed teeth and wound up putting posts and screw posts, and things happened. You got partial dentures. In the 1970s, I had two shades, gold and silver. There we have the silver fillings, and we were really artisans with gold. We could burnish the margins. We cemented them in with zinc phosphate cement, pH of 3. But we could make that gold. We cast it, invested it, divested it, and the more shiny it got, the more cosmetic it got. So that's what we had. They both matched. I mean, those were the only two shades I had. I want you to look at this pyroplast onlay bridge, and this was done in 1975 by me. And it's still in the mouth. It's 40 or coming on 40 years old. I waxed this up. This is Peter K. Thomas anatomy. I cast the gold. I put the pyroplast facing in. It's still there, and it's not going anyplace. I want you to look at this gold. Everybody needed gold requirements in the 70s, and I did an MID lingual inlay, gold inlay on the tooth. And if you take a look at the back of it, yeah, it's chewed up a bit, but it's still there. That's minimally invasive. You still have options. I saved some tooth structure, but I want you to ask yourself, is your dentistry going to last that long? So now, I'm going to fast forward you now. You're in the adhesive era. I was in the pre-adhesive era, and now I came from extension for destruction. That's GV Black. You are in prevention for extension. We have two different worlds, and I've transitioned, and I don't want you to go back into the world that I came from. Now you're going to go into minimally invasive with a new classification for preparation designs and say goodbye to GV Black, but remember what he said in his philosophy. It's true. Now, I was introduced to the new white fillings in the late 70s and the early 80s, and we got on board. And we started taking apart quadrants, and we started putting in the white fillings, and they failed. There was no bond strength. We didn't have adhesion. We were told not to put phosphoric acid on dentin, otherwise you kill the tooth. And I worked without gloves in the patients for a good portion of my career, and I was your test pilot. I'm the one that showed these companies how to improve because we failed. So these are your MID restorations right now. Now, I want you to remember something. It's not if your dentistry will be replaced, it's when. Your work is not going to be permanent. If they say, Doc, is this a permanent crown? They say, nope, it's not permanent. Either will you or me. It's not if my dentistry is going to be replaced, it's when. Let's talk about biofilm now. This is the essence of minimally invasive dentistry. This is where ground zero is right now because biofilm is sophisticated. You take a prophy cup with pumice on these teeth and you get that tooth shined up and cleaned up. That biofilm goes back in about 10 to 15 minutes, and it's very sophisticated. You can have 1,000 different microorganisms that communicate with each other, and they invite other microorganisms into the colonies, and it's very difficult to break down. You'll never get rid of biofilm. The goal is to have a healthy biofilm. This is the chart on demineralization in time. And over time, on the upper right quadrant, you have a very acidic environment that's been demineralized with a low pH over a period of time, and this is what happens is you get irreversible processes going on in cavitation, and you get dental caries. That's a function of time, and that's a function of the concentration and the low pH that exists in the oral cavity. And all that time was a chemical imbalance that nobody touched. I never touched it. I was never trained to touch it until recently did we get involved with this. So I just was a surgeon removing disease, replacing tooth structure in an unfavorable environment. The goal is I want to be a physician today and intercept and diagnose versus being a surgeon and just cut out the disease. Now, here's what happens when you get plaque on teeth, and when you get into an acidic environment, you get acidic plaque, and what they do is they will actually get into the outer 300 to 500 microns of enamel called demineralization, and the hydrogen ions, the acidic ions, go into the tooth, and there's an instability that takes place with the calcium phosphate and fluoride ions in the tooth, and this is called demineralization. Now, what can we say is from these observations that not all patients have similar success rates despite similar treatments. Everybody's an individual, and the sooner you understand how to diagnose these things, the better off you're going to be, because then you can explain why things are either succeeding or failing. Similar restorations behave differently in different mouths. Everybody's going to be different. And for you, doc, your new docs, I want you to understand is good restorations will fail in a less than favorable environment, and less than ideal restorations will survive in a good environment. So if you think you're a good dentist and you're dealing in a bad environment, you better get that environment changed before you want to show everybody how good you are, because otherwise your work is not going to last too long, and you're going to go back into redo-odontics before you know it, and the risks go up. Okay, what do? I'm more into wellness. I think this is a trend that you should get on board, is all my patients get their saliva tested for the pH, especially high-risk people. Is my staff, the hygienist, my assistants will have them spit in the cup, and we check the saliva with a piece of litmus paper, and what that shows, I don't charge for it, and what that shows, it's either going to be green, yellow, or red. Green is good. That means that they're high alkaline patients, that they're buffering. Yellow is caution. Something's going on. The pH is dropping. They're getting into demineralization area, pH area. And red is bad. And if you see a red on the litmus paper, that means these are acidic, whether they have a resting saliva that's acidic or moderately acidic. That means you should intervene and get them involved in some pH strategies and how to raise the pH of the mouth to buffer that saliva so you can't get the acid-producing bacteria out. Here's what you want to do is I want you to ask in your initial checkup, when did you get your first cavity? This is going to be very important, especially in females, because at age 12, the females go through puberty and their saliva, their acidity could change in their resting saliva. When they go through pregnancy and menopause, their saliva buffering can change and they can be predisposed to dental decay. You'll hear the stories about this, but these are 3 breakpoints in the females you should be aware of. Become proactive with differential diagnosis. The other thing is I want you young dentists to understand is ask after you diagnose decay to say, how old is that crown? If you have decay under the crown or decay under the filling, say, how old is that? When was that done? Because if it wasn't done too long ago, you may ask yourself, why is that decayed versus sucrose by the patient? Now, if it's a bad-looking crown and some dentist did it as a 30-year-old crown, and now you've got decay around the margins and all of a sudden the saliva changed, if you put a brand new crown in an acidic environment, your crown may last 3 to 5 years, and they're going to patients just tell you didn't do a good job. Protect yourself, know the environment, and know what you're doing. Now, the other thing I want you to look at is the plaque. You look at these young people coming in, they could have wall-to-wall plaque, and if you remove that plaque and there's no white spot lesions and demineralization there, and there's no decay, and they just have poor oral hygiene, they probably have alkaline saliva and they're buffering and you get no decay. Here's the key. If you get into adults with interproximal decay on the lower, the mandibular anterior teeth, they probably have sick saliva that's very acidic, And usually you don't see that on the lower teeth. You only see maxillary decay from sucrose. But when the key is that when you get mandibular interproximal decay, you better test the pH of the saliva and see what's going on. There's bad plaque and good plaque. We have to prevent the good plaque from turning into bad plaque, and that's the check the oral environment and check the buffering capacity. 3% of the population of all the bacteria are the bad guys. This is the lactobacillus, the mutant strep. These are the bad guys, and there's only 3% of the population. Here's the thing, we have to keep the good guys on the playing field and quarantine the bad guys so they don't influence the whole community of bacteria. When you have plaque that's acidic, they're very unstable, and in the presence of sucrose, it can't hold on to calcium phosphate and fluoride. It gives it off to the oral environment and steals it from the tooth. And I literally mean it. It steals, and that's called demineralization. And if it goes too far beyond the outer rim of the enamel, it cavitates, and that's when you become surgeons. So you don't want eco-disasters in the mouth. People understand eco in green. Talk to them about that. So now, let's go back to our slide. And now, you new young doctors, this is where I want you to land, and this is where I want you to practice. The function of demineralization over time, I don't want you to get involved with cavitation and treating surgically, only if you have to. I want you to spend more time as a physician taking blood pressures like a physician, checking cholesterol like a physician, only you're going to be checking the pH of these patients on the resting saliva, the stimulated saliva, and understand how they can get this risk under control and before it gets into cavitation and to surgery. That's your whole future is going to be predicated on how soon you can get over there. So let's talk about this before we accelerate into the restorative part, is that in the mouth, if you can buffer, the humans can buffer with calcium out of your parotid glands and your stimulated and resting saliva when the pH is greater than 5.5. And if that pH drops below 5.5, there's a problem, and you have to diagnose this and get on board and treat it. Here's what happens now when you are going to start looking in the oral cavity, and I want you to learn the International Caries Detection Assessment System and the classification that you're going to go with a Mirror and Explorer. What happens when you get into a score of 2? You look in there and you say, let's watch this one. No, you're not going to watch it. Let's put a sealant on it. Well, how do you know what's in it? Because there might be some degenerative changes. There's some changes in the outer enamel. You have to be very careful. This is where a minimally invasive dentist gets into the tooth and becomes proactive and intercepts any of the outer rim changes. So I would take a minimally invasive burr and do a partial fissurotomy and understand that a sealant would not be a good deal here, and either would GV Black. What we do are minimally invasive preparations, because now I'm into the dentin. I'm taking microburrs and I'm restoring it with minimally invasive dentistry. When you get into the score of 3, now you've got a problem, because you can see darn well you're into the dentin of the tooth, and you take your Explorer, and what you're going to do now is numb up the patient, and you're going to take, hopefully, not a large round burr or 557, you're going to take micro burrs and start cutting down and see where the disease is. And then for me, I take minimally invasive burrs, save the sound enamel on the cavo surface outer rim, and just take what I can underneath it, and then put therapeutic glass ionomers in here or flowable dentistry in there and protect all that sound enamel whenever I can. Unbeknownst to you, a study in 1994 by Adrian Lucy said that the Explorer is only 14% efficient in detecting of decay. That is not a good ratio, so I don't want you to be totally tethered to your Explorer as the divine instrument. Is that I want you to be involved with things like Diagnodent, things like Sable and Seek from Ultradent, These are decay detecting. You can put it on a occlusal surface and see where the demineralized surfaces are. Cavo makes this diagnodent. It looks for the fluorescence in the groove and the translucency, and it'll give you a readout and tells you where the risk is. Get involved with diagnodent. That's going to be a good one as well. When you get involved with microarmamentarium, there are burr companies like Brasler, Comet, Shofu. I've patented my own minimally invasive burr kit from Brasler. I get no royalties, but it gives me an opportunity to take the smallest burr and open up, just like an orthopedic surgeon doing scope surgery or a vascular surgeon replacing a heart valve with a scope. We're taking out small areas of the tooth. So here you see in the sequence where I would get a readout of 35 on a fissure. I would do a fissurotomy using minimally invasive and then do flowable dentistry and keep the tooth structure intact. So you have to ask yourself now, as I'm wrapping up history, when I'm doing minimally invasive dentistry like this and getting into minimal destruction of the tooth, will it last as long as some of the 50-year-old dentistry today? So I'm going to go faster through adhesion now, and then we're going to run over a little bit if it's okay with my sponsor, and because I burned up some time here. What I want you to pay attention to is you're going to be marketed now into adhesion dentistry being faster and more predictable, and I just want you to take a step back and use your intellect and see if this is going to be good, because when you get into dentin, this is a unique complex that's hydrophilic, and it doesn't like to be dried like enamel. And there's smear layer in here. It's a unique web-like complex. So if you get into total etch with phosphoric enamel, phosphoric acid, you're going to remove the smear layer and open up the dentinal tubes. And if you're going to use self-etchers and collapse the smear layer, you're going to keep the smear layer and don't open up the dentinal tubes. You get to decide. One is total etch, and the other one is self-etch. Etch and rinse, and no rinse. One is wet bonding, more steps, more things that can go wrong, and the other one is dry bonding, less steps, less things that can go wrong. And if you use total etch with wet bonding principles and you dry the dentin and collapse the collagen fibers, is what happens. You can go from a 26 megapascals and collapse the collagen fibers and get to 13 megapascals, and you have no bond strengths. So your adhesion is, again, the golden standard of time. So give your adhesion a chance to go through the collagen fibers, get through the mineral component in a hydrophilic environment, that fill up the dentinal tubes full of liquid called dentin bonding agents, and go according to manufacturer standards. And so you can accurately build in a good environment from the hybrid layer to the resin layer to the composite layer, and build good predictable restorations. Let's talk about how you're going to talk to your patients. Okay, some of the ground rules I'm going to coach you with is, first of all, don't use dental terminals. If you didn't know the word before you became a dentist, don't use it to your patients. They don't understand it. Communication is what you say. Connectivity is how you feel. And you want to let the patients know that you're human, that you have their best interests in mind versus your best interest. Do not put your balloon string on the air and tell them how good you are. Tell them how empathetic you are, and that you understand finances, you understand their emotional status, you understand that you are in their world, and before you want them to get into your world, and that means you have a good supporting team that agrees with you, that respects you. When you're out of the room, they're going to say, we respect this person that's going to work on you. Never try to talk somebody into something. Bad idea. Never presume you know more about them than they do. They may have gotten laid off. They may have illnesses in the family. They may have some problems in the family that you don't know about. Be very sensitive to what they're saying and be very professional about it before you offer a restorative solution. Always tell the truth of what you see, even if it's good or bad, even if it's your work that didn't work. Be very honest to say, I'm sorry, I have to do better. I want to redo my own work. There's no cost to this, and it happens, and I'm standing behind it. I want you to tell them, this is what I see. No matter what the disease is, this is what it means to you, and this is what it means to me. Here's the risks, whether it's low risk, moderate risk, or high risk. This is how these conditions can affect the quality of your life. If you don't deal with it, it can come back and you can lose work. You can be in pain. You may not get a hold of me on a weekend. So how do you want to manage the risk? This is the health implications. Let's talk about some cases now. And again, I may run over a little bit, but if it's okay with my host, I will do that. Let's talk about ortho cases. This is what comes if you are an accredited dentist and you have studied with world masters and you can master resins and do no prep about people coming out of ortho and the orthodontist send them to you. This is not where you want to start. These are the pre-op pictures, and I'm just doing no prep bonding on the front 6 teeth. And this is all freehand bonding using 2 or 3 different colors. This is what you can do if you're technically trained. And again, I don't want you to start any of this kind of restorative care until you are taking a lot of hands-on workshops. This is life. This is good dentistry. This is how people seek you out on the internet, by reading your articles and taking your courses. Take a lot of courses before you do that. This is our case here. This is finding a cure for a childhood disease. Here's a 12-year-old patient, very self-conscientious. She grew up to be a beautiful adult, and she comes in with a lot of stigma and emotional trauma that a dentist back in her teens tried to cover up the discolorations, was not a very kind individual, and scarred her emotionally. And she was very reluctant to even talk to me about this until we discovered that we could bond together, that I was very empathetic, and I was in her corner to find a solution without destroying her teeth. She did not want veneers. She didn't want anybody to take apart her teeth unnecessarily. And here you see the band of discoloration that had been covered over by some other dentist's resin fillings that is no longer appropriate. But on the occlusal, on the incisals, you see it's looking pretty good here. So, I mean, shade tabs are shade tabs. They're not going to really help you too much. I got news for you. You make custom shade tabs made out of the material that you want. And then we talk color, and then I strip off the old composites, and just to see what's underneath and see what the difficulties are. You could leave them alone. She wants that out of there, so I'm going to be doing some minimally invasive dentistry. So I guess I get 5 minutes right here. So let's see if we can get back on our slides. So here it is. I'll keep going here. We've stripped the teeth down. I've made custom shade tabs. I preview the shade tabs on the teeth before I take the teeth apart. I draw with pencils where I'm going to do minimally invasive dentistry. I got minimally invasive burrs. I'm just going to cut down into the enamel just a little bit to get rid of the discoloration. Here are my preparations that are repairable, minimally invasive, relaminated, and they can be repaired in the future. This is selective etch with phosphoric acid. Rinse and dry. This is demineralized enamel. This is your dentin bonding agent. Whether you're using total etch or self-etchers, this happens to be self-etch 7th generation that I use. put the layers in incrementally. This is the dentin layer put in, like the tooth was formed with undulations. I've been trained as a ceramist as well, and this is how ceramists build. And then I isolate using dead soft strips and then finding my final enamel shade. This is what my layers look like after I light cure them. I spend a lot of time building them. And then I draw lines where I want my line angles to go. Again, this is training as a ceramist. I don't want you to do this right away, but this is what's possible with a lot of years of training. And then I use good products from Shofu and other companies with the disc systems and how to move line angles, how to use 30 fluted carbides and how to pre-adjust the surface, how to use green stones to create diffuse architecture, how to use silicone and one-step polishers and finishers, how to use final buffing capabilities with luminous oxide paste, and how to use diamond impregnated paste. This is high-level aesthetics. This is what's possible. I want you to do basic dentistry to start out with, and this is what you get. This is minimally invasive dentistry. This is repairable, reversible dentistry. I know how to build, I know how to make teeth, not how to make good-looking restorations. And this is a minimally invasive solution with aesthetic options into the future, assuming you know how to do minimally invasive dentistry. Patients are happy. This is what they look like. So what can we summarize? I know I went fast. What I can summarize from the presentation is, Devan said it right, the goal should be the perpetual preservation of what remains, then the meticulous restoration of what is missing. You are going to be preoccupied on your fillings. You're going to be preoccupied on your crowns. You're going to be preoccupied on what you replaced. I want you to be locked into what you remove first and how you do your preservation of tooth structure, your diagnosis of the oral cavity, and the pH strategies. That's what I want you to do. Now, let's keep going and see if we have any questions. Okay, let's see. Was it one patient or faculty who got you to see things in a minimally invasive way? I'll tell you who it was. It was later on in my career. 1993, I hit the wall. I was doing destructive dentistry for money, and I had to reinvent myself, and I went to the best instructors I could find, world-class instructors that were so far ahead of me, and they had the patience to take me on as a student and mentor me and tell me what this was all about, is not only to be a better clinician, is that I had to be an educator, and after that I had to be a publisher. And when this is all said and done, I'm giving back to dentistry more than I'm taking out. And that's kept me in balance throughout the remaining years of my practice, is how much can I give back to you? And I've taken so much out, there's going to be so much for you to take out, but give something back at all costs. That's what I want you to do. And I really want to wish you well and say goodnight to you, and hope to see you in one of my courses, and I hope you read my articles. And you are in the sweet spot right now. You have no idea what's going to come your way. It's all going to be good if you pay attention to what you're doing, be competent. You're on the bottom of the totem pole. You always put those people around you and the patients up first. You'll do fine. Do not take things apart that you have no business. Do not talk your way through a procedure. If you don't know what you're doing, they're going to find out real quick, and your assistant's going to find out real quick that you don't know how to build teeth. Tell the patient. So again, I want to wish you well in your careers, and look in the literature. Invite the dental companies into your practice for lunch and learns. They're essential for your survival on what's coming through. And I want to thank NEXTDDS and Shofu for co-sponsoring this tonight. And we're going to ask you to fill out a quick survey underneath and get your feedback on if this was important to you. How did I do? You get to grade me. And remember, your patients and your staff will be grading you. So good night and have a wonderful career. Thank you.